Clinical examination of the central nervous system. The vestibular nerve and the otolith apparatus of the inner ear may be tested at the bedside by examining for nystagmus and by position tests. There's horizontal nystagmus on lateral gaze with a rotatory component usually indicates a recent disturbance of the vestibular nerve. Its central nuclei or connection, or occasionally the semicircular canals, as long-standing peripheral lesions are not associated with nystagmus. Positional tests may allow the symptoms of positional vertigo, as vertigo induced by sudden head movements, to be distinguished into central and benign peripheral types. The patient is moved quickly from the sitting position to lying with his head back and turned to one side. So this change of position may either give rise to immediate vertigo and nystagmus, indicative of a central cause, or lead to vertigo and nystagmus after a latent interval of about 15 seconds. So this later response is indicative of a disturbance of otolith apparatus in the inner ear. It is usually a benign self-limiting condition attributable to a viral infection or head injury. It is noteworthy that structural lesions affecting the auditory nerve in the posterior fossa, such as acoustic neuroma, give rise to a perceptive deafness, usually associated with some degree of trigeminal sensory loss and facial weakness. So where a unilateral perceptive deafness is found, it's careful examination or careful testing of the corneal reflex and facial movement is very, very mandatory.